All right, with that, I'd like to welcome everyone. Thank you for coming, and thank you to Dr. Mackenzie and Dr. Osman for coming to present on newborn screening. Dr. Mackenzie is one of our wonderful researchers and clinicians here in Canada and very respected internationally. One of my heroes for a long time already, and I don't want to say how long.
Tearing up.
And Homira, she's with Muscular Dystrophy Association, and through a grant through Novartis has been spearheading the newborn screening and is happy to share all the information she can for us to learn and know what to do and where our next steps are going to be. So with that, I hand it over to you, Dr. Mackenzie.
Okay, thanks. Hi, everybody. I can't see how many dozens and hundreds of people there are, but hello, everybody. C'est en anglais aujourd'hui, mais si vous avez des questions en français, vous pouvez me contacter après peut-être. Et pour notre translator, Gerard, je essaie de parler lentement, unlike I usually speak, as Susie knows. And actually, what I'm going to do, I'm just going to quickly talk about the situation in Ontario, which is a little bit old news almost, and most of you will know. And then we'll segue quickly to Homira, who will talk more about the more important, I think, pan-national thing. I think the battle to some extent may have been won in Ontario, and it's on the panel, and it's getting the results we hope for. And so, as Susie well knows, our next, I don't want to be too militaristic, but our next front is the rest of Canada. So yes, basically this is my talk, but I stole the slides from Kristen Kernahan, Pranesh Chakrabarty, and Hugh McMillan, three of my very esteemed colleagues here in Ottawa. And full disclosure, I'm funding from both Biogen and Novartis, and Biogen, hats off, funded the SMA Newborn Screen. It could be argued were important, absolutely critical in getting it going in Ontario. So basically, very quickly, the Wilson and Jung group back in the day gave the reasons why one should screen. And I know Homira is going to talk a bit more about this, but a condition should be important. There should be an accepted treatment. And luckily we have treatments, as you guys, everyone has heard at the meeting. It should have the ability to diagnose as well as treat should be available. There should be a test or examination where you can identify it and make the diagnosis. The test should be an acceptable one to the population. And then the natural history of the condition should be known, and there should be an agreed policy on who to treat and not to treat. And the cost of finding and treating versus not should be well established. And so SMA really ticks off all those boxes, and Homira will talk a bit more about that. I just want to talk quickly about some of the biology about SMA screens. If you look at the protein which causes the disease, the absence of this protein called SMN, you can see in this very good work from Charlotte Sumner and others that it really is very high in the prenatal period, even in the first 3 months, and it drops off after 3 months. That is when it's critically needed, the SMN. And even, and this is old work from Kathy Svoboda, but in the bottom right panel, one can see even for type 3, the loss of the motor neurons occurs relatively early. Type 2 and type 1 even more so, with rapid loss of motor neurons. So quite clearly, diagnosis of SMA early on will bring the best results with treatment. Essentially what we do in newborn screening, we approach the parents, we discuss the newborn screening, outlining the benefits, we tell them how the testing is done, we discuss the timing with them, we tell them that a repeat sample is sometimes required, and we discuss the difference between screening and diagnosis. This is very important. Some people think if it's a positive screen test initially, it is a diagnosis. It really isn't. You need the secondary screening for that to happen. You discuss the possible results and you answer the questions. And in the case in Ontario, we gave them a brochure that covered some of the aspects of SMA. It's done by the heel prick, a lancet in the heel, and the famous dried blood spots there that we do the tests on. We get the SMN test. The timing in Ontario is such that we want to do it within 1 to 7 days after birth. What am I doing with the animation? I really went crazy here with the animation. Between 2 days to 3 days after birth is really the best time. And after a positive screen result comes back, we want to get the the confirmatory, what we call secondary screen, 5 days, no longer than 5 days after. So a baby is born and it doesn't appear that they have any SMN1 gene. Within 5 days of that first screen, we want to have the second answer there. And when you get the screen positive results, it does not mean necessarily the infant is affected. Further testing is required. What happens in Ontario, NSO stands for Newborn Screening Ontario. Basically, NSO gets in touch with a regional center, and that can be Thunder Bay, London, or anywhere within the province. The treatment center notifies the infants and the healthcare provider, as well as the parents, and they arrange the secondary treatment, and the report is mailed out to the referring hospital. If it's confirmed, the regional treatment center provides the management, counseling, and in the case of SMA, the therapies. So that's the way it works there. That's sort of the view of how it works. Just quickly, the history in our case, we started way back in 2017, filling out these various forms, Form 1, Form 3. Ultimately, by 2019, we had it all squared away, and they said, yes, I won't bore you guys with the details. I was sort of the principal investigator, getting a lot of help from Biogen at this stage, as well as Pranesh and others. And we sort of got it through. And in the end, there was a 1-year pilot project funding from Biogen that kickstarted it back in 2020. And so the way the screen works very quickly is that there's a sample and something called a mass array SMN assay. And fundamentally, if that is shown to be positive, we do a secondary test. So there's 2 phases, initial and confirmation. We look for the presence of both the SMN2 gene, which is the helper gene, and the SMN1, which is the actual gene which causes the disorder. And just not to get too much into scientific weeds here, but fundamentally, this is a person without SMA. You can see they have the little peak with SMN1 there and SMN1 there. There's 2 tests that we do to make absolutely sure. And this is the SMN2 peak. A child with SMA will have no peak there and no peak there, just the SMN2 peak will be seen. And this is what we look for. The secondary test is something called MLPA, and that will tell us the number of SMN2 copies. It'll confirm the actual SMN1 missing, but it'll also tell you how many SMN2 copy numbers, which is important for the actual therapeutic decision. And so just quickly, and I'm sure Gerard, I'm going too fast for you, so I do apologize. I'll buy you a nice bottle of red wine or something. At any rate, the dried blood start arrives, we screen it, and if it turns out there's no SMN1 copy, we check and see how many SMN2 copies. And if it has 5 or more, we say that's it. We're not going to call that positive. If it has less than 4, or 4 or less, we say it's screen positive. We tell the family, they do the confirmatory testing. If the tests are the same, then we go on. It's called true positive. The diagnosis is made, and Hugh McMillan, Craig Campbell, one of our heroes, comes in and does the evaluation and then starts the treatment. And just quickly, we've done 214,000 infants. We've had to repeat 400. It's because it looked like the initial screen, but ultimately only 10 positive samples have been identified to date in the last 18 months, 1 in 20,000, 21,000, a bit lower than we assumed. So that is very quickly it. And this is just an example of a therapy, and all the children have been treated to date, a therapy of Hugh McMillan's, where basically the newborn screening was done at 10 days old. So screen positive was at 10 days of age. He did the neuromuscular examination at 11 days. He gives Spinraza at 24 days, Zolgensma at 37 days, and then at 10 months, completely developmentally normal, despite having just 3 SMN2 copies numbers. And so just an example of what can be done. And so that was it at a real trot, 8 minutes. I hope Gerard's head didn't explode. And I'll just, happy to field questions, but let's pass it over to Homira, okay? I just have to say, Dr. Osman and along with Stacey Linton have really pushed the newborn screening agenda over the last 18 months. They've been huge advocates. So thank you very much for the work you guys do. I'll stop sharing. Have I already stopped sharing? Okay, I'll put myself on mute.
Thank you so much, Dr. Mackenzie. I really appreciate this opportunity. I hope my slides are showing up okay. Thanks again, Susie and SMA, the Conference Planning Committee, for providing us an opportunity to provide an update on the initiative. And much of the information that I'll be talking about today does complement what Dr. Mackenzie has started to speak about. So we'll go ahead and just jump right in. If you take anything away from today's presentation or from my portion of presentation, is the time is now. Time is neurons, as we're calling on provincial and territorial governments to add SMA to existing newborn screening programs. I want the message to be clear that this is the right time. And it's not just about a call for action, and that's what you'll hear about today. It's really about convening the right stakeholders, providing the right information, bringing families, individuals impacted to help influence positive change. But I would be really remiss if I jumped right into the initiative that we're working on and didn't take an opportunity to really highlight a major catalyst in starting this initiative. And this is in relation to the work that has been done in Ontario. Ontario continues to be the only and the first province in Canada to have SMA added to the newborn screening panel. As Dr. Mackenzie spoke about it, it all started with a Biogen supported pilot project, beautifully seamless transition to policy within a number of months. And since then, some of the data that Dr. McMillan and Dr. Mackenzie have supported was provided. And you can see families like the one indicated on this article have really benefited from an early diagnosis. This was a great catalyst and a great starting point for us to then enter into a collaboration with Novartis Pharmaceuticals Canada, who have an interest in supporting newborn screening. MDC, Novartis, I'm sure Biogen, Cure SMA Canada, we all don't believe in postal code health. We would like for individuals outside of Ontario to also have access to early diagnosis and access to making informed choices at the beginning of life. And so this landmark effort is really to bring together those with lived experience, the experts, patient advocacy organizations, governments, and other stakeholders. So we entered this partnership in December 2020, and I want to provide an update of what we've done so far. But before I do that, I wanted to share that we've really taken a stepwise approach, a phased approach in terms of getting provinces added or getting SMA added to provincial newborn screening panels. The first component was doing a needs and readiness assessment. And then we launched a call for proposals. We will soon be launching an additional call on September 15th. But another phase is really looking at evaluation and knowledge transfer, taking time to reflect on what we've learned so far and how we can apply this towards policy adoption. This initiative is not about just having projects in place or pilot projects. It's really about going from pilot straight to policy. And then the fifth phase is to use this scenario and this example as a case study for harmonized newborn screening. What we're doing right now is going province by province, territory by territory on different timelines. Ideally, it would be nice if there was a harmonized newborn screening program in Canada where there would be consensus to add SMA, and then it would be implemented by the different newborn screening programs. To provide you some information around the needs and readiness assessment, this information was gathered using a variety of different methods. There was interviews conducted with clinicians, with subject matter experts. There was also a survey that was done. We looked at peer-reviewed literature on newborn screening and also looked at a jurisdictional scan of newborn screening programs in Canada. The goal for the needs and readiness assessment was pretty simple. Connect with the clinical, public health, and laboratory experts to understand what is the current state. How easy is it if tomorrow you get that decision that your health minister says, yes, we're ready to go, we're adding SMA to the panel? What would that look like? How many months would it take? Do you have the right infrastructure? Is there political readiness? Is there clinical readiness? And to understand the trends and limitations, the barriers, what are facilitators? And also to look at cost analysis. So as part of this needs and readiness assessment, the vendor that we worked with was able to look at readiness across a number of different dimensions. And some of those dimensions I just want to highlight, and you'll hear more about in today's talk. really knowing if there is an existing infrastructure, such as the lab already conducts screening for SCID, another chronic health condition with a pediatric onset. If there's accessible treatment and adequate reimbursement, if there's high readiness among clinical stakeholders, if there's an existing infrastructure in the province to confirm a diagnosis through genetic testing and MLPA equipment is available, and if there's a favorable environment to add SMA, and that is from the clinical laboratory, but also from the patient advocacy organizations advocating for this. Is there public dialogue? So to date, we have completed phase 1 and phase 2, and you'll hear more about it, but I thought I would sort of shift the way I'm talking about this into what have been our top 5 questions today. And as an organization at Muscular Dystrophy Canada, where we represent a broad set of neuromuscular disorders, one of the common questions is, why SMA? Why aren't we adding Duchenne to the panels? Why aren't we adding Pompe disease? Why SMA and not another neuromuscular disorder? A common question that we get, and I was at Jerhan's talk earlier this week, costs come up a lot whenever we talk about policy and the rare disease space. So another question is it expensive to add SMA to the newborn screening panel? Is it cost effective? Another question is, what about ethical considerations? So you have Spinraza that is well reimbursed across provinces, but that's not the case for Zolgensma or Risdiplam. Although they are approved by Health Canada, is the time really now? Is another question we get asked. What are the barriers to adding SMA to a newborn screening panel? Shouldn't it be a no-brainer? If Ontario did it, why isn't anyone else doing it? And then what is the current state of newborn screening for SMA in Canada, and how can I help? So let's go to the first question, and this was already discussed by Dr. Mackenzie. There are a set of principles or criteria that is outlined on whether you should add a disorder to a newborn screening panel. And if we look at SMA, we know that SMA is an important health problem, that there are accepted treatment options for patients with SMA. And to the question around, if reimbursement is not there, if an infant were to be diagnosed today, they do have access to a treatment option at least, and even having early access to that treatment option can present with important health outcomes. It also is important from a criteria perspective is whether there are facilities for diagnosis and treatment for SMA, whether there's early signs or early presentation of SMA, whether there's a suitable newborn screening test, which we know there is, whether newborn screening is acceptable to the population, whether there's an agreed upon policy on whom to treat, and the cost of case finding by SMA newborn screening is economically balanced. I'll be able to speak to some of these, but in terms of whether SMA is an important health problem, I know for this audience, I don't have to do any convincing, but everyone here knows that based on the age of onset of symptoms and the maximum motor function achieved, SMA is classified in different types with different severity. And without treatment, and depending on the severity of the condition, it can impact life expectancy. It can impact motor function. It can impact the ability to sit, walk, and breathe, quality of life. And so therefore, SMA is of course an important health problem. As I mentioned, there are accepted treatment options for patients with SMA, as were simultaneously Cure SMA Canada, MDC, CORD, RQMO are working towards improving access to treatment. We already know that there is access to these treatments and that these treatments are already approved. With more, and in addition to this, there's supportive treatments that are available, such as comprehensive rehabilitation that can lead to greater potential outcomes. One thing that came out loud and clear in our readiness assessment is we've got robust clinical infrastructure across the country. The map that you're seeing looks at CNDR clinics or clinics as part of that track as part of the clinical neuromuscular disease registry. But we have a number of clinicians, academics, researchers across the country providing state-of-the-art care to patients affected by SMA. Here on the screen here, you're seeing Dr. Campbell from London as an example of a pediatric neurologist who's really doing some wonderful work and improving the lives of his patients. As you know, there is a window of opportunity. That's why we do really say time is neurons. There have been several studies. It's very clear in the literature that early diagnosis is important and can have important implications on health outcomes. I mentioned that component around the readiness scores of having SCID in your province, if that has already been part of the panel. The reason why that's important is there is a method or a way that you can multiplex SCID and SMA. And so it's nice. It really helps to have those two conditions together on an assay and to get tested. With that said, you can still test for SMA without having SCID, but that is a component as well. And it is clearly acceptable to the population. And without early diagnosis and treatment, there can be accumulation of comorbidities or early death in some of the types of SMA by type 1. There's also an agreed upon policy. The clinical group within Canada is excellent. There's a most recent paper that was done through the Neuromuscular Disease Network for Canada, led by Dr. Osman, who spoke yesterday at the conference. In this scenario, it was a guidance on gene replacement therapy in SMA. What's really nice, and I've heard this from many of our clients as well, is they really find that the SMA community from a clinical perspective is tight-knit. There's a lot of dialogue, a lot of exchange. Shared decision-making is also a key component between the SMA experts and the child's parents as well. So if I can switch to whether it's cost-effective, the answer is yes. Newborn screening and early treatment for SMA can save both lives and money. The cost of screening outweighs the cost of illness. Cost of illness is some of the work that we're doing right now at Muscular Dystrophy Canada. We just wrapped up a study where we looked at the cost of living with a neuromuscular disorder, SMA being one of them. Dr. Hugh McMillan also conducted a study together with the support of MDC and Cure SMA Canada on cost of illness of SMA. And we do need other studies that can also look at this, but even just most recently, just a few weeks ago, there was a study that came out from Australia where they were able to look at newborn screening for spinal muscular atrophy. And the response was very clear. Newborn screening coupled with gene therapy improved quality of life, length of life for infants with SMA, and was considered value for money from an Australian clinical and policy context. What about ethical considerations? So when you're thinking about diagnosing or in a family identifying or learning about a new diagnosis of SMA, what are the ethical implications? There was a study that was conducted that looked at this. The clear answer is, while there are advantages and disadvantages to an early diagnosis, there was consensus that it is important to access an early diagnosis. That it was really helpful from the perspective to get early management options and potential to see improvement in clinical outcomes. Some of the disadvantages were more around the potential for stigmatization, the challenges around learning new information relatively quickly after diagnosis. But with those disadvantages even in mind, it was clear that it was important to have access to an early diagnosis. So the advantages of early screening outweigh the disadvantages. Again, even though all treatments are not currently reimbursed, it was really important to have access to treatment choice earlier and to then start the process towards it between that shared decision-making if there was a need for another treatment to get that process started. Newborn babies in Canada have the right to be diagnosed as early as possible by newborn screening for SMA in order to get optimal health care. This is part of the UN Convention on the Rights of the Child. So what are the barriers? When we did this needs and readiness assessment, funding seemed to be a primary barrier. It was consistent and a primary barrier to why SMA has not been added to newborn screening panels. Some provinces said they did not have SCID screening, severe combined immunodeficiency syndrome, on their panel as well. But you've heard today that you can still continue to have newborn screening for SMA without SCID, although it is helpful from a cost-effective and from the methodology perspective. Another barrier is we're still in a pandemic, so there's significant public health needs. Some of these labs that would potentially be screening for SMA is likely also screening for COVID. There's an opioid epidemic that was mentioned by public health or decision makers. Those seems to be competing public health priorities. Another barrier is that for some provinces like Saskatchewan, the newborn screening committee has dissolved. So there was not really a clear pathway of how to add a new disorder to the panel. So length of funding, budget restrictions, intense, lengthy, and unclear process, lack and limited public dialogue, lack or limited public motivation were there. But there are facilitators. Support from a united advocacy voice was clearly a catalyst and a facilitator for groups like SMA Canada, MDC, CORD, RQMO, Love for Lewiston to work together, avoid duplication, and really work together to present a united voice is really important in a key facilitator. Existing SCID screening is a key facilitator. Clinical and academic support, strong clinical expertise, approval of therapies. Newborn screening for SMA was recently noted in CAD at the 9S recommendations for Zolgensma, and also in the case of risdiplam. What is the current status of newborn screening in Canada? So as you might have seen, as a result of our first call, and thanks to Dr. Mackenzie for his leadership and being part of our peer review process, right now, we have been able to fund projects in Alberta, Manitoba, and Quebec. The gist of the overall goal or call for the projects was not necessarily for pilot projects, but for projects that will essentially help to accelerate the adoption of adding SMA to the panel. So what that means is, again, if your health minister tomorrow says, yes, I'm ready to implement this into policy, what is the work that we can do to start this work in terms of adding SMA to the panel? As we know, there's many layers and steps involved. We're really grateful that Alberta has already declared that they will be using these funds toward the pilot study for a year, and then from there, going into policy, modeling after the work that's been done in Ontario. Same with Manitoba. And the work that's being done in Quebec is also really important around the clinical pathway following a diagnosis. So lessons learned, and how can you help? In terms of lessons learned, I think the initiative has told us a lot about the power of partnerships. MDC has come together with Novartis. That is a unique partnership, but it's been so instrumental in helping to make this work. MDC has to come together with like-minded organizations like Cure SMA Canada to help make this possible and help to leverage our individual different expertise areas to help make this possible and to continue to help make newborn screening a reality across Canada. I think another piece is our role as a convener, bringing together the right people to the table to help make decisions. And not as a funder alone. Even though funding was cited as the #1 barrier, there still seems to be a lot of barriers that we need to help to support. And I think that that is great in terms of MDC being in a position with the support of Novartis to help manage those barriers. It's also been a great lesson in mobilizing evidence, knowing your audience, how you can take evidence from a peer-reviewed literature, evidence from our clients and their life stories and life experiences, and translate it and present it to different groups and audiences. How do you present that to government and make a clear case? I think this has also been an important lesson in the variation between provinces in terms of processes, in terms of the who's in charge of making these decisions, and the incredible value of person and family-oriented advocacy. Living with a neuromuscular disorder such as SMA includes a lot of challenges, a lot of time investments, a lot of barriers. There's a lot that families are enduring and encountering. But with that said, so many of you have lent your voice, your story to help really propel this initiative forward. There is an engaged community in Canada, and I think that that has continued to be an important catalyst in helping to increase the number of provinces that are adopting SMA into their panels. So how can you help? We're happy to have your help. We're happy to let you know what's going on in your individual provinces. While this map right now reflects the provinces that have received funding, Stacey Linton, our CEO of Muscular Dystrophy Canada, and I have been really in touch with a number of different stakeholders within the different provinces, are in a number of different discussions and really helping to make this work. So we're happy to hear about your personal experiences, interests, and we can share opportunities to help make this happen. I have to say it's incredible that Novartis has committed to up to $2 million of funding in this initiative, while MDC is not using any of that funding towards our operations. It's purely for the study, for this initiative. It's also really helpful that other major donors, supporters, firefighters, clients have come forward to ask how else they can help to really make sure that this map turns red, that all provinces and territories are screening for SMA. So with that said, I hope I've made it clear, Clay, that the time is now, and that we thank you for your support and ongoing commitment to making this a national reality.
Great. Thank you, Homira. Thank you, Dr. Mackenzie. I have a question that's been put forward by one of the patients, and they were hoping you could go through province by province on where they're at individually.
That sounds like a Homira question for sure.
For sure. Why don't we just jump up to this map just to kind of keep us there? So in terms of Ontario, let's start there. Very pleased that it's a confirmed policy. In terms of Alberta, what we know is they are currently in the works to set up their pilot program. And at the beginning of the new year, new calendar year, they will be setting up that pilot program. It will be a pilot program for 1 year, and then it will shift into policy. In terms of Manitoba, they are receiving this funding to help set up a pilot program, and is working closely with their government to ensure that pilot is also translated into policy. In terms of Saskatchewan, you'll see that it's under this projects pending section. We're working really closely with provincial leads in Saskatchewan. We hope that as part of the next funding call, we'll be able to make a formal announcement, but I'm quite optimistic about Saskatchewan also having a SMA added to their panel. And there is an engaged clinical community there from a pediatric neurology perspective, from a lab perspective, that is committed to helping to make this a reality in Saskatchewan. In terms of Quebec, right now, we have a project that is funded. As I mentioned in Quebec, the project that is currently funded is more around the post-screening pathway. So after you receive a positive screen, which clinics do you go to? How do you optimize that pathway? How do you make a consensus in terms of recommendations and next steps, which is really important. But at the same time, we are working and meeting with different members of government as well to help ensure that that information can be leveraged to help with the adoption, but also what can we do to support? Right now in Quebec, there is an INES, the drug regulatory body, that is undergoing a review of whether to add SMA to the panel. We're working closely with the individuals overseeing that recommendation to see how MDC, together with Novartis, can help support that province in ensuring that beyond that, what we are hopeful of a positive recommendation, that it becomes a pilot program or straight into policy as well. The Maritime provinces is another, the 3 provinces in terms of New Brunswick, Nova Scotia, and PEI, where we're working closely to ensure that they have a pilot program in place. And we're hopeful that as part of the next funding call, as of that will be on September 15th, we'll be able to help that group as well. In terms of what you'll see in terms of the territories, those are covered by the provinces as well. They are split up by the provinces. So that leaves me to talk about BC and Newfoundland. I think we're probably having the most challenges with understanding or supporting Newfoundland in terms of adding newborn screening for SMA in that province, but we're really committed and keen to support. And we are in discussions with BC, trying to understand better some of the barriers. There's a committed community there from a clinical perspective. We're engaged with the lab directors as well, and also talking to the policy decision makers. But there's some more work that needs to be done in BC and Newfoundland. So in terms of where you're looking at the map right now, I would say it's really, really great and optimistic to see Alberta and Manitoba looking towards these pilot programs. I would say we'll continue to work with Saskatchewan and Quebec to help turn this into policy, and then the Maritimes as well in terms of pilot. So a lot more work to be done, but really hoping that we can leverage the strengths of one province and help to share those findings to make this possible across the country.
Thank you. That was great. Does anybody have any questions for the speakers? If you do, just please unmute yourself and go right ahead and ask. Hi, Jan.
Hi. So thanks for the presentation. You give us a few reasons to explain why it's so long to implement the newborn screening, but in fact, does the process doesn't just start too late? Do we have an explanation? Is it a provincial or national law who make why they wait the approbation? Often they have some disease. They put they implement the newborn screening even if they don't have drugs to treat them. So where we have to knock to fix the problem, because after us there will be have another drugs and for other disease, but it's always too long. But why they cannot start before the process?
So why does it take so very long is the question.
And why they don't start before? You know, in the SMA community, we saw the drugs coming 7 years before the approbation. So why all the authorities don't just track this kind of drug and start the process to be ready when it's when they've got the authorization? There's no way to push to be sure they start the process before, if it's possible and pertinent.
Yeah, I mean, Homira, I think every province, every region has a different mixture of barriers, is my impression. Homira, you clearly know better than I do. Jan, I think, and one is not always allowed to say this in public, I think there is tremendous anxiety in the healthcare funders that on dit en français après SMA peut-être le déluge. There may be some anxiety about the number of medications that are coming for a variety of rare diseases and sustainability. So I think that might also be a factor. But I think, Homira, you can add to it, but there's a variety of different barriers. Homira, I don't know what.
I agree. There's a variety of different barriers between provinces. I think that probably is one of the barriers, right? Is that it's not a harmonized newborn screening program where there isn't a mandate that's made to add SMA. There isn't a committee like in the US with RUSP where they make a recommendation to add a disorder. I think there's one thing there too, but Jan, you remind me of two other points. One was around the federal government has committed to a rare disease strategy, and Durhan spoke about it so nicely earlier this week. I think when we talk about the rare disease strategy, or when we've heard discussions about the rare disease strategy, it's been around treatments, high cost treatments, a rare disease strategy around treatments. But I think the point I'm trying to make here is when we talk about the rare disease strategy, we need to incorporate newborn screening or early diagnosis. That rare disease strategy needs to be comprehensive from time of diagnosis to access to treatments and rehabilitation. So I think there's that point. But then the other thing I was going to say is this initiative, while centered around SMA, and the entire discussion today appropriately so, is centered around SMA as an organization that represents a broad set of neuromuscular disorders. We're already thinking of how do we do this next time with Duchenne quicker? How do we do this next time with Pompe disease in a more efficient manner? How do we do this? How do we take these learnings so that it's not just a one-off every single time with every single disease thinking, okay, we have to wait for all of this to then help influence change. So I think that is what this initiative is all about. Of course, we want to turn that map red, but then we want to do a lot of knowledge translation, a lot of knowledge transfer and exchange to make sure that this is applied to other disorders as well, neuromuscular disorders.
You sound like a member of the Canadian women's soccer team about the map. I want to change the color.
But, I just wanted to add to that, and that is one of the crutches of this situation as well, though, because the concern about approving something like this for the SMA community is setting precedents for other diseases and having them come along behind. And we have seen, all along with advocacy for, approval for treatment, that's been, one of the problems all along, is their concern about who's coming up behind. Yes, this disease, this test, these patients need access, but then who's going to be pushing right in behind us? And there's a lot behind us. And that's been one of the burdens on our community, but this is our fight for access.
We need to make Jan happy. That'll be our goal. We need to make Jan happy.
Jan is always happy. He's a happy guy.
All right. Go ahead, Jan.
Yeah, I would like to know, maybe with the Dystrophie Musculaire Canada and the relation with the federal health ministry, like we saw in the media a case with a young autochthone. He received the gene therapy via the Jordan principle. So the drug is paid by the federal because he's autochthone. I would like to know if the relation or the contact you have with the federal authorities have input about the fact in the different provinces we have a lot of inequality, and I think they think there could be a solution to put in a big national pool. Is it something you talk with the federal authority?
Yeah, I don't know, Dr. Mackenzie, if you have had more discussions at that federal level, but I think right now our approach has really been province by province, because even within provinces, it's understanding, doing some stakeholder mapping, understanding the right stakeholders there to help influence change, or who are in charge of this decision making. I think the time we've really discussed that has been in the consultations around the rare disease strategy, where we've tried to shift their discussions from high cost drugs towards a comprehensive strategy around early diagnosis, early access to treatments, and these interim programs that can help while there's PCPA negotiations and all that, where perhaps the federal government can help to support. That's really been the discussions around SMA newborn screening with the federal government. But I think that's where phase 5 will come in. If you might remember, that's where that case study for harmonized newborn screening, that will be, our audience will shift towards the federal government, where we can present this approach of where we went province by province, territory by territory, and what was the learnings from that, which, as I'm saying, that seems so inefficient, and clearly everyone would agree.
Mm-hmm.
Thanks for your answer.
Do you have any other questions? Please feel free to unmute yourself. Just go ahead and ask. All right,
I have to go unpack my carts at this point, or else I'm going to be in trouble. But yeah, anyway, but I mean, absolutely. So if there are questions that occur later on, Homira gave their emails. My email is very Googleable. I just want to say quickly, how impressed I am at how passionate families who already have a child affected with SMA, who will not benefit necessarily themselves from newborn screens, are the most passionate advocates. This is a huge altruism on people like Susie's part, where basically this is advocating that the children of the future will not have the same, not have to wait the same way that their own children did. So I'm always very moved.
I think that's really important to mention too, Dr. Mackenzie. Yep. So as part of this newborn screening initiative, while you could see the partners being Novartis and MDC, we do have an advisory committee, and we have parents affected with a child affected by SMA on that committee. While Susie's there representing Cure SMA Canada also as a parent, but Mike Lowe in Alberta has a toddler affected by SMA. Yeah. Laura Vanderbilt in BC, and it's so important. Jessica Johnson from Love for Lewiston is also on this committee. It's really nice to see people bringing their lived experience, their story, helping with an initiative that, to your point, won't necessarily benefit them on a personal level directly. But I think that's the spirit of the SMA community. Everyone is willing to do whatever it takes to help move it forward for the future. And hopefully, in terms of the future, SMA newborn screening is a reality relatively soon. So thank you again to the community for rallying support.
Yeah, and thank you to muscular dystrophy for heading the battle on the newborn screening, and we're excited about collaborating with muscular dystrophy. Just, oh my goodness, this is the end of the long conference. I can't talk anymore.
Okay.
And Alex, thank you, because you're the one that started the entire thing, and
Okay.
can't thank you enough. And the humble man that you are, and you want to cut me off so that I don't say how wonderful you are, but I'll say it again. You're a wonderful man.
Okay.
So
All right.
yeah, thank you
Okay.
so much.
All right. Enjoy Monday. Okay. All right. Bye.
All right.
Bye.
Okay, have a great day, everyone. Thank you so much.